Welcome to dentalxp.com Webinar Wednesday. I'm Dr. Maurice Salama, and tonight we will be having a special preview edition of our Partners in Synergy program, which will be held June 27th through the 30th of this year in the Ritz-Carlton, Grand Lakes, Orlando, Florida. Once again, it's a pleasure for me to share the podium with Dr. Michael Picos, and tonight's webinar event will be sort of a preview of what we're going to be showing in our 3.5-day immersion program on current trends and technologies in bone and soft tissue augmentation as it's related specifically to dental implants. This course, which is given every 2 years, is usually the highlight event for both Michael and myself, and we certainly are always excited about sharing this with both the general restorative dental community as well as the surgeons and periodontists who join us each and every time we give this program. So I hope that you'll take the opportunity of coming to join us in Orlando this year. You'll see the banners to the left of the screen that you can click on if you want further information. And certainly without further ado, I'd like to introduce my dear friend and colleague, my partner in Synergy, Dr. Mike Picos.
Thank you, Mo. It's certainly great to be here this evening. I want to welcome everybody to this session. I'd like to proceed with just a few cases, actually 3 of them, to share with you that will give you an idea of some of the things that I like to do in my practice. Entitled this Synergy of Bone and Soft Tissue Augmentation in Tooth Replacement. In essence, we're able to share these images and, most importantly, to identify the fact that they've not been altered or manipulated. Certainly in this day and age of digital technology, we can grow bone, we can grow soft tissue at the push of a button. So we're able to make sure that we share this slide with you. Extraction sites, certainly, as Maurice mentioned, this is a really hot topic without question. There's so many ways to handle extraction sites with regard to both hard and soft tissue regeneration strategies. This particular first case I'd like to share with you is a 38-year-old, very attractive young lady who came to us with concern of having had a upper central treated over the past 7-8 years with endodontic therapy. She had had a traumatic fall at a younger age and subsequent root canal therapy ×2, as you're going to see radiographically here in just a bit. But first things first, this is how things looked when I started to evaluate her. High smile line. We can identify a number of items here that are of concern, but first things first, if we just look at this from a, just look at my tools here in a second. If we just look at this from a pure pathology perspective, obviously we've got this area right here to be concerned about for obvious reasons, without question. And in fact, if we go to the next slide, radiographically, as one would expect, this young lady's had some apicoectomies ×2 and is now finding herself in a failing mode with this tooth. So again, attractive young lady, high smile line. The biotype is a thick flattened one, so that's in our favor with regard to whatever we do for her. Her desire was to have a single tooth implant. She had read up on this, had done some online research, talked to some friends, etc., and realized that a bridge would not be quite appropriate for her in terms of her desires and wants. So that said, it proceeded as you see here in terms of the extraction, but just in terms of thinking and thought processes, I'd taken a CT actually on her after the fact, unfortunately. But if you can see here intraoperatively, there is really no no bone, as evidenced with the probe that I have here, the actual dental curette. This entire area, actually right in through here, as I probed with a curette, with various other instruments intraoperatively again, no plate, no labial plate present. Different strategies to approach this type of a case certainly could involve more recently bone morphogenic protein. We've been using that now in a number of our cases, but we need to offset reality in terms of cost benefit to our patient. If we can achieve a similar result with a much less hard cost item to us, then certainly that will play a role in terms of what we treat, or I should say, will dictate one of our treatment options. So let me proceed and show you that here, and I typically, in cases like this, like to treatment plan with particulate mineralized allograft. And as I've outlined in Inside Dentistry from last year, first quarter it was published, as you'll see here, had some management guidelines for evaluating tissue degradation. This comes under the severe category, meaning in terms of labial plate loss, we're looking at greater than 6 millimeters. In essence, again, the entire labial plate being is missing. And for cases like this, what I've been able to successfully utilize as far as strategies go is what I term an MBA, or mineralized irradiated bone allograft, with a connective tissue graft, depending on tissue volume deficits. And in this case, we have certainly a thick biotype, but we do have the dehiscence. A thin biotype would also dictate the use of a CTG as well. Potentially reevaluation then after a period of time for either a monocortical block graft with another potentially use of a CTG, or in many cases, and in most cases, complete regeneration, as we'll see, of the labial plate, or if not complete regeneration, adequate to place an implant and do a guided bone regeneration procedure. Well, here, as you can see, I'm attempting to create a bit of a pouch, and keeping, of course, intact the entire facial aspect and all these extraction sites in the aesthetic zone. No release incisions are made, and we haven't done this in a number of years. So we're able to literally, with just cellular incision approaches, a tunnel like you see here, and then a connective tissue graft is placed in a position with this more or less marionette type suture. We're able to utilize a nylon suture, in this case 5/0, and bring up the connective tissue graft in place such that we're able to secure it on the facial, as you see here, and then now able to place the mineralized allograft, specifically Mineros. Now, what I've found over the years is that of all the bone products I've utilized for socket grafting and related particulate grafting, this material in itself, this mineralized allograft, has properties that really are exceptional in terms of predictability. In essence, the regenerative capacity is so exuberant that in a case like this, as you'll see, we're able to regenerate the entire labial plate, or most all of it, in a period of anywhere between 6 and 8 months. Our typical extraction sockets, where we've got 2 to 3 millimeters of labial plate deficit, we'll wait 4 months, and that gets regenerated nicely with no membrane, surprisingly enough. And I found this out through trial and error, that even without a connective tissue graft, if we have adequate facial soft tissue drape, then what do we use to cover this? A number of ways to handle this. Many times we use a free gingival graft as a plug. Kobe Landsberg's and Nichan Bachacho's approach of basically a socket seal, or many times a connective tissue graft, as you're seeing here, tucking it under the labial, under the palatal flap, and securing it with another horizontal mattress, again 5/0 nylon, and that secures it quite nicely. Here you see an Essex retainer, and I've really got excited about Essex retainers a number of years ago when I first heard Maurice actually talk about this, and I think he was one of the first to really make this rather mainstream for all of us, and I've enjoyed using it. Prefer this over a flipper, especially as you see here where we've harvested the connective tissue graft and the wound site many times can be interfered with a conventional flipper. So this works out quite nicely. Another key point is to make sure that the allograft the Minoros here is placed in such a mode that you're literally at bone level but not tissue level. I think a common error is to overpack in terms of vertical height, being even with the soft tissue. You really want to be right at bone, which means you're a good 1.5 millimeters or so sub-soft tissue, and then that allows your connective tissue graft to really come over that nicely and drape well. Another good point about Minoros is it's a combination of both cancellous and cortical bone. It's a gradient, 0.6 to 1.4 millimeters, which really allows what I found over time, because I did use a mineralized allograft for some 8-9 years, Puros, which works extremely well. Same D2 bone density that we'll get at similar time frames, but this cortical and cancellous gradient together adds a better dimension in terms of predictable bony integrity, and it's less expensive of a product. So that certainly plays a part in our day-to-day realistic decision making, certainly for our patients. Here we're at 6 months, and of course a two-dimensional radiograph isn't going to tell us too much with regard to the width factor, but our soft tissue drape is looking good. And now re-entry, my approach has been now for quite some time more of an H incision, meaning mid-crestal and sulcular only, as you're seeing here, and just enough of a flap on the facial to take a good look at, I should say reflection on the facial, to take a good look at what the labial plate looks like. And here it's intact nicely. We're able to come in now with our this large round fissure burr I like to use to more or less simulate and recreate our contour such that we can place the implant in a vertical dimension with approximately 3 millimeters of running room from the base of that implant body to the CEJ of, in this case, the adjacent central. Assuming we like that length, then what I do typically is create this arch right at the 3 millimeter number, apical to that CEJ, and then my implant body, in this case is tapered internal laser lock implant, will be placed right at that point. And you're seeing the labial plate approximately 2 millimeters. We've recreated it nicely, and here's a 3-month follow-up. These implants are placed in typically non-submerged. I like 3 millimeter height healing abutments, parallel walled, that allow for enough soft tissue closure, but not over the top, so to speak. And here you can see we've maintained a nice margin from the crest, I should say from the implant body rim to our soft tissue drape on the labial. Now, our final result, certainly from a prosthetic perspective, we can look at this and critique it and have maybe perhaps a little better result in terms of contour of the crown here. We've held up nicely with our soft tissue drape. Our point contact is a little bit high. Could have been certainly a little bit more incisal. You see the smile line, actually she really smiles with even more gingival display. But to the patient, she's very happy with this result, and we're able to, most importantly and impressively, obtain adequate bone volume and, most importantly, density. In this case, a D2 quality bone, which I have, by the way, many cores taken over the years utilizing Minoros, and with the same results, anywhere from 60 to 70, 80% vital bone, very impressive, even at 4 months, with complete regeneration of the bony integrity of that socket. This was taken approximately 2 months post-prosthetic completion. So she overall was happy. You know, we can nitpick, and certainly as we blow these up and magnify these cases, and especially on a large screen, we can certainly nitpick, as we all do, and we're all striving for perfection all the time. But the reality is, depending again, and not to point fingers at all, but the prosthetic experience level of this clinician was really more almost entry level, believe it or not. But still, not a bad result. But again, most importantly, being able to predictably regenerate bone in cases where, and this is an N of 1, but I have many to draw from, and in fact, I'm working on a paper just with these alone where labial plates are completely gone, and we're able to regenerate these plates with this particulate mineralized allograft. Now, going to case 2, this is a little different twist. This is an 82-year-old physician and internist here locally, and fine gentleman. He has problems with both 8 and 9. They actually both had some fractures, and were referred to me by one of our good restorative dentists who very much is into cosmetic dentistry, but implants based as well. And as we see here, our gingival biotype, which how often we certainly bring up and talk about, that many times, in fact, most all the time, will dictate, have a large say in terms of what our end result will be. And as John Coyce has always talked about, and especially in his compendium article in, I believe, 2003, 2004, his 5 key principles of peri-implant related issues for single tooth replacements, there's no doubt that in spite of what we do, this really is the big predictor. I think you'll agree in terms of what kind of an end result we can get from a predictability standpoint. The thick biotype, and it's here, it's in our favor, and with both teeth in trouble, there's certainly some discussion with regard to should we take one out at a time and graft or place implants immediately in order to preserve that interproximal height of bone between the central incisors, or should we just throw the dice and take both out? Well, as we will see here, both 8 and 9 labial plates were missing. So this adds really another dimension to the potential problems that can occur, especially with immediate placement. And again, this isn't the case in my opinion or my comfort zone to place implants at the same time. Having labial plate missing, and again being adjacent implants, I've got concern. We do have bone on the interproximal site with our lateral incisor areas, and that's in our favor. Once again, this is in the severe category where we've got greater than 6 millimeters of labial plate loss, and from a simplistic perspective, we can be again look at these options. Monocortical block graft would be still an option, but not right up front. And again, with the fact that we're able to obtain such a predictable result with the mineralized allograft, here we are again. I'm placing this in both sites, no membrane, and I'm sure this will come up at some point of discussion. You know, why not a membrane? Well, don't need a membrane, as I found out, again, through trial and error. And in fact, with this biotype especially, here you're seeing a free gingival graft or a plug taken, harvested from this hemipellet area. This is a day post-op, by the way. And here, a small membrane, a PTFE, a cytoplast membrane, was used on the left side. So in a sense, a little split mouth design, if you will, free gingival graft here, or autogenous versus allograft. And as we see here, 6 weeks later, removing the PTFE membrane on this on the number 9 site, you can see that there's a little bit of collapse here of overall tissue volume versus the free gingival graft site, for what that's worth. Now, this is only 6 weeks, and Mo, I don't know if you have any comments with regard to this issue. Autogenous versus alloplast always comes up. When do you use a membrane versus autogenous? Connective tissue grafts certainly could have been used here for both sites, you know, etc. Here we are at 6 weeks, removing the cytoplasm membrane. Now 9 months, actually at 7 months plus would have been adequate time, I think, for turnover of this bone, but this gentleman wasn't able to return to us till the 9-month mark. But in looking at our sagittal views with cone beam CT, which certainly is an invaluable tool, and the only tool, by the way, to truly evaluate what we're dealing with. Do we really have bone regeneration or not? Is that plate back or not? And here, as you can see clearly, with the right central number 8 and number 9, that plate is definitely regenerated at the 9-month mark. And our reentry, we have different ways to approach these cases. I like personally to preserve this interdental papilla in doing an 8-9 case, but still using this more or less H configuration in both the right and left side, as you see here, and obtaining core biopsies, which we do often, to compare and contrast the materials that we evaluate. Here, able to obtain cores from both sites. And thanks to Harry Prasad from Minnesota, these micro CT specimens are really impressive because they denote a number of things. In fact, quite honestly, there's such detail here that I don't quite understand all the ramifications, except to tell you that the relative density, as one can see just here and here, pretty impressive. And so the longer we wait, we go from a D2 to a D1 quality bone, again, with this mineralized allograft. Very impressive. Here you see I was able to, again, contour these central incisor zone areas appropriately to allow for, again, optimal three-dimensional implant placement in terms of width, height, mesodistal, I should say, facial angle, and the vertical dimension. Placing, in this case, these are, again, bi-horizon tapered internal laser lock implants. I like the fact that these micro channels really work to our advantage. This laser lock technology is very impressive. I was somewhat skeptical at first, to be honest with you, until I began to see the results of what these little 8 and 12 micron channels actually do in terms of soft tissue integrity. And this is, of course, a 1000 blow-up SCM. But most impressively, the fact that we have these microchannels to utilize, and as we know now with Ron Nevin's landmark study that was published about a year and a half ago in IJPRD, looking at the histologic evidence of this epithelial downgrowth inhibition, and most impressively, a good connective tissue attachment that we'll see on this scanning electron microscopic view here. And of course, the connective tissue is colored, as you see, but there are the channels right there and there. But more importantly, clinically, what we see is the same effect, meaning I can barely probe a millimeter around most any of these implants, even at 4 and 5 weeks out, and obtaining up to an 80-85% bone-to-implant contact is very impressive, to say the least. So here, again, evaluating the appropriate vertical dimension in terms of where to place the implants optimally for good emergence profile, etc. We're seeing our labial plate, in this case, a little thinned out. And as we know, we can utilize a veneer graft effect here with something that is relatively non-resorbable. And specifically here using BioOS,
this is
a bone matrix mineral rather that really serves a good purpose. We don't want something that's going to be resorbed, at least not quickly. So using it in this little pouch technique really works nicely to do two things. One, cosmetically to plump things up and make things look good if we have a high smile line, certainly. But more importantly, in this case, to add a adequate, or I should say additional thickness to our existing labial plate to protect that implant body long term. We all have our cases of gray-black coloration, discoloration that we cringe when we see and hope to say that That's not my case, but it is. This is, in the next slide, I was able to conveniently borrow, with permission from Mo. Really, what Uli published really hits it right on the head. And those of us working in the aesthetic zone for so many years kind of figured this out on our own, whether we realized what we were thinking or not. But we for sure never quantified it. But we understand that, yes, you need some definitive thickness, some metric to say, yes, 2-3 millimeters, pick the number, but there's got to be some consistency. If we can see the implant body as a translucent reflection through the labial plate, you've got to know that's not a good thing, certainly not long term, and that will become problematic for us. So that minimum of 2 millimeters, without question, plays a huge role in the overall aesthetic effect of our implant success, without question. And here we see this gentleman completed, and time doesn't permit to discuss occlusion so much, but there's no question that plays a huge role in all of our cases, and we do evaluate that scenario right up front. But you can see he's got incisal wear with the lower teeth, but a stable dentition after all these years. But impressively here, I think, is to see the papilla that's been maintained quite well. I think you'll agree that we got a very good result with simultaneous extractions, grafting, and then simultaneous implant placement with delayed crown fabrication and placement. Two-dimensionally, we have we can only get so much information. Certainly, there's our peak of bone, and approximately we can maintain good papilla height. But if we look at the real holy grail, so to speak, that's available to us now, and that's cone beam, that we now use routinely with our cases, not just pre but post grafting, to make sure that we've got adequate bone turnover for implant placement, etc. Here you can see we've got very nice labial plate integrity with both central incisors, complete regeneration maintained well, and of course that's really what it's all about for us, to make sure that we have a predictable long-term result. So that said, just want to move along with the time remaining that I've got with this last case. This is a 21-year-old young lady. We all see these patients coming to us with congenitally missing lateral incisors in the upper arch. And this young lady has a high smile line, as you can see. Good biotype in our favor. More of almost like a hybrid type, a bit of a cross-section between thick and thin. But most importantly, evaluating, again, with cone beam CT. This doesn't do much for us. A PA or panoramic, any 2D evaluation of these sites doesn't give us the whole picture. Clinically, one develops a feel here to say, sure, we probably have a width deficiency. That's the acid test. That tells us and shows us dramatically what's going on with the number 7 site. And number 10, even more dramatically, we can see this relative width deficiency, certainly inadequate to place implants, at least in my opinion, in cases like this, and try to regenerate at the same time. So we can begin a workup utilizing a number of software packages available to us, in this case using the VIP software that's very straightforward, very easy to use. Through BioHorizons, we can treatment plan what the implant abutment crown complex would look like in both of these sites. And then this is confirmed intraoperatively. As you can see from this incisal view, occlusal view, the undercut areas that we would expect to see from the workup. And to me, these types of cases, yes, one very predictable approach, one treatment approach certainly is utilizing a block graft. In this particular instance, harvested from the right ramus buccal shelf, and using our piezo surgery technology, which I've now been playing with for about 5 years and have found it to be invaluable with not only harvesting blocks, preparing recipient sites, outlining our sinus approach, sinus grafting approaches, ridge splitting, failed implant removal, tooth removal, etc. As you can see, we prepared our sites for the block grafts. We fixated them. We know that they are successful. The success rate has been in the high 90 percentile for a number of years now, not just with my own numbers, but certainly many others reporting with similar success rates over the years. Just a few of the publications I have on this topic, using, again, not just a block graft, autogenous certainly, but over grafting with Mineros is a very a predictable way to fill in any small little gaposes, if you will, and also using a bioactive modifier, in this case PRGF, plasma-rich and growth factors, for the past 4+ years. More recently, I've been using this as a very impressive growth factor complex, along with the fibrin clot that is also part of this particular technology. And just quickly, those of you not familiar with PRGF, Dr. Eduardo Aditua really is the brains behind this technology in Vitoria, Spain. And it's really an autologous preparation rich in growth factors. A little different than PRP for sure. Spin down is a little bit different, but it's this fraction 3 that has the bulk of the growth factors that we utilize. And from a soft tissue perspective, without question, we have seen impressive results. And also from a hard tissue perspective, with our particulate grafting, we've seen exceptional turnover. No leukocytes in the preparation, no bovine thrombin required for that coagulation cascade. And there's some very interesting properties that, if time permits, we'll be able to cover them in the Q&A on this technology. But here's a 4-month follow-up on this young lady. And as you see, we're able to compare pre and post, both right and left side, as you'll see now. This is still the right side. There's our pre. The value of a post-graft CT, whether it's a block graft or a sinus graft, can't be emphasized enough to know what are we dealing with. We don't want surprises when we open up a flap and attempt to place an implant. The old days of becoming red-faced and double talking and sidestepping to a patient saying, geez, I don't know what happened. The bone just didn't turn over, whatever. Those days are gone. We know for sure we've got the bone volume we need. There is no guesswork. Same thing with the left side. We're able to evaluate, again, pre and post, that graft in place nicely, secured well, 2-point fixation. And very impressively, too, for the past 4 or 5 years, why flap these as I did in the old days, able to permucosally take these screws out in a very, very minimally invasive approach, and can then place our implants with our surgical guide, and again, still able to contour as we need to where the appropriate height of bone needs to be for that emergence profile to be optimal. Primary closure around those abutments, and then this is approximately an 8-month follow-up post-prosthetic completion. And I think you'll see with this biotype, I called it hybrid. It was really on a relative thin, almost highly scalloped biotype, really. We're able to get a very nice result here, as you can see. But again, how do we verify? Is it 2-dimensional radiographs that really we utilize the most? Not really. It's really the 3D. And this tells the whole story. We have more than adequate bone volume on the labial aspect of both implant sites to be maintained long-term, to prevent ideally that grayish discoloration that we all dread, but most importantly from a functional perspective, to make sure that these implants are there long-term. So that pretty much completes my part of this webinar. Just a couple quick words with regard to the institute that I've had now for, this is our 20th year, and I'm very excited about what we have done and what we're able to continue to do. But most importantly, being able to interface with folks like yourselves over the years from all 50 states and 32 countries has been just a lot of fun. I've thoroughly enjoyed it, and especially my collaboration with Maurice has just been exceptionally solid. It's been one of the highlights of my professional career. I've enjoyed it, and that said, Mo, I'm going to turn this over to you. I want to again thank all of you for being with us this evening, taking time out of your busy schedules. We're most grateful to have you on board and look forward to seeing you again, hopefully at Synergy in June.
Well, Mike, I have to say, once again, it really was very well put together. I didn't expect anything less. And I think it's a good opportunity for us now to change over to the second phase of the lecture.
Critical thinking in aesthetic implant therapy, or reasons for failure. As you see in this case, obviously a case where 2 implants were placed to replace the right central lateral incisor. We have a significant soft and hard tissue defect in this area. The healing abutment's now displayed, and you can see that the soft tissue framework has been lost substantially, even though the bone has healed to the implant and an autogenous free gingival graft was utilized. There still seems to be a substantial aesthetic compromise in this case. And most of the time, reasons for failure are incomplete diagnosis, which I think is important that we recognize why this may occur, and of course, inadequate treatment selection. Should we use 1 implant, 2 implants, what size implants, and then of course whether or not another or additional grafting procedure would have been necessary prior to instituting implant replacement. So we're often asked, is there a formula for grafting success? Is there a formula for tooth replacement success with implants? And really for us, we narrowed it down to 3 significant variables that we look at in each and every case that we treat. We're going to try to minimize failure. We're never going to completely avoid failure, but if we're going to attempt to minimize failure, what we need to do is focus on those elements. And for us, really, it comes down to X, Y, and Z for our office, and we've been looking at these for many years now, and now doing a study with Stephen Chu and Dennis Tarnow to further look at the impact of bone and soft tissue grafting in the aesthetic zone. Really, gingival thickness would be the X variable. We know the research from Ronald Young, who suggests 2 millimeters of tissue is required in front of the implant. We need to know how to augment tissue, what different variables and different techniques are utilized to augment tissue in these situations. What type of flap approaches? Are we going to use tunneling? Are we going to use acellular tissue? Then we have the labial plate, which Uli Grunder first spoke about back in 2005, where he suggested a 2 millimeters of labial bone beyond the facial aspect of the implant body to protect it against future resorption and for stability of the soft tissue margin. And then, of course, along with Dr. Tarnow and his group, our group in 1998, and again over the last decade, really speaking about the importance of understanding the location of the interproximal peaks of bone, which is the Z variable. So in a type 1 case, we would have thick tissue, 2 millimeters of thickness. We would have 2 millimeters of bone available in front of the body of the implant, and the interproximal peaks of bone would be within 4.5 millimeters of the future contact point of the restoration. If you recall Mike's first case, the reason that the soft tissue filled interproximally because Mike did a beautiful job augmenting the bone and had very, very nice interproximal peaks, and that soft tissue eventually filled in that area. So if we looked at the critical measurements clinically, it would be thickness of tissue, measuring this 3 millimeters below the gingival margin. Of course, we shouldn't see the digital readings through the tissue, something that we learned from Joseph Kahn. We want to know where the labial plate of bone is, so we go down until we bone sound for the labial plate of bone. And then, of course, the interproximal peaks of bone, just labial to the contact point and in front of the transitional line angles. Today, we can also use CT scan technology to evaluate this as well. Let's take a look at a patient who's been in a denture for many, many years against a lower dentate bridge work, has really had severe resorption. The patient's intention is that she wants a conventional restoration. She's really young at heart. She's a young 72 years old, and she really didn't want to be in a denture any longer and did not want a removable prosthesis. She wanted to have a bridge like she had on the lower arch. If you take a look at what occurs over many years when you have teeth or implants against the edentulous ridge, we end up with substantial resorption. Here we have completely pneumatized sinuses on the right and left side. You take a look at the CT scan, you can see the knife edge ridges that we're dealing with and a very, very thin bone quality. This would be what we would call a dental cripple, an edentulous patient. And as Mike showed you, the importance of CT scan technology is that even where we have bone, we have a significant thin maxillary anterior ridge, and then in the posterior, we really lose most of the bone to the pneumatization of the sinus. So this is a challenging case. We need to place enough implants, hopefully for conventional restoration, but before we even think of that, we have to start considering our toolbox and regenerative protocols to rebuild this patient's deficient maxilla, both in the anterior with some form of graft, as well as in the posterior with sinus augmentation. Obviously, multiple sections of CT scans are required. We want to be able to evaluate the sinus to make sure there's no pathology, things that Mike will discuss in great detail during the Synergy course in June, to evaluate to make sure that we have proper drainage, that we don't have polyps or infection in the sinus. And we also look at the axial cuts. You can see how extremely thin this cortical bone is, and there's no bone at all to work with for dental implant placement at this time. So we have severe bilateral sinus pneumatization. We're going to evaluate this patient for grafting. And really, when we start to look at this, we start to think about whether we're going to use a crestal approach or a lateral approach to the sinus. And really, there's a lot of different techniques today. These are techniques I'm sure, again, will be highlighted and discussed at the meeting. We've seen people such as Ziv Mazor, as well as Samuel Lee on this very site, who presented crestal approaches to the sinus through balloon techniques or through specific types of burrs to access the sinus through the crest. Or lateral approaches today have also been changed somewhat. We have drills that are neurosurgical drills, such as Neobiotech, actually just used today, to enter the sinus wall laterally very quickly and very efficiently. It cuts through the bone and does not harm the Schneiderian membrane. Obviously, piezosurgical approach can be used laterally and crestally as well. So we have a lot of different approaches today, which approach to use and what's best. What we did here is to use the neurosurgical drills, the Neobiotechs, to gain access through the lateral wall, and we grafted the sinus, as you can see here, with a substantial amount of mineralized irradiated bone, mixed 50-50 with xenograft and PRGF, platelet-rich growth factor, a BTI product that really was first brought to my attention by Dr. Eduardo Anitwa. Some implants were placed in the lower arch at the same time, and you can see that what we want to do with a completely pneumatized sinus, maybe today, Mike would suggest utilizing maybe BMP rather than utilizing particulate bone. We want to wait 8 to 12 months and take another CT scan before ever coming back and placing our implants. At approximately 9 months, we were able to now take a duplicate of her denture that we were going to be utilizing as a guide, and we can start to plan the placement of the implants. And we're doing this strategically so that the implants will come out exactly where the occlusal table will be. So we're going to angulate them so that they're coming out exactly where the future restoration is going to be placed, right through the central fossa for best biomechanical load. If you take a look at the x-rays on the left side, we have severe pneumatization, but a very, very good sinus, a healthy sinus with no signs of infection or chronic problems. Sinus grafts were instituted, implants were inserted at 10 months into the grafted sinus areas with a minimally invasive approach. And this really has a very high success rate in terms of sinus augmentation, very low infection rate, very high success rate with different methods and a lot of different techniques and a lot of different materials that can be utilized with growth factors today. I think that this can be by itself a very, very important discussion, and we usually takes place during our Synergy meeting, and I'm sure Mike will go into great detail about what to do in terms of evaluating timeframes, in terms of waiting before placing these implants, and if certainly after placement, to wait before loading them. Usually in a pneumatized sinus, usually 8 to 12 months, and then place the implants at 9 months. In this case, we waited an additional 5 months before ever considering the loading of the implants. Now we went ahead and placed 8 implants, 4 on each side, the posterior right and left, and we waited 5 months while the patient healed before loading them with a fixed bridge. And while we were doing that, one of the implants failed. The maxillary right, first bicuspid implant failed, and sometimes what we have a problem with is where the denture is, even with a soft reline, is loading the healing abutments. We sometimes get some loading of that fixture prematurely that may cause loss of the fixtures. And that's one of the challenges that we have with the edentulous patient. We can't protect the loading, intermittent loading of the implants as well as we can with a fixed restoration. We went ahead and took the post-op PAs. You can see very, very good bone apposition to the implants. You can see on the CT scan how we had very, very good bone fill in the sinus and the post-op CTs, and Mike talked about that. One of the great things about CT scan technology is not only that we can plan the surgery, but we can evaluate how well the surgery did with a post-op CT scan, either before and again after implant placement. What we then did is we took our impressions of the posterior implants with a plan to then add more implants with a temporary bridge fixed on the posterior implants to protect it from loading during early healing. So implants in the posterior grafted area support the original fixed bridge, while then we go to the anterior area and we're going to add this implant back at that time. Once the temporary bridge has been facilitated, we now have a non-loaded environment. The bridge is in place. It's going to be able to protect whatever we use in this anterior region. And we really have a knife edge ridge, as you can see here. There's a lot of different options today. Certainly, as was just spoken about, block grafts from the ramus can be utilized. This patient was very, very much opposed to going through her mandible. She was 72 years old, had been told that this is a very difficult procedure. Also, she had the nerve in the mandibular right and left that was not ideally suited for ramus grafting, and she was not interested in autogenous bone from the chin. So what other options are there? Mike talked about we need a certain dimension to even consider ridge splitting. I think 2 millimeters is a minimum before I'd ever think about doing that. Certainly I'd like more than that, and I want some type 3 or type 2 bone so I can split it. When it's very dense bone, it's more difficult for us to do ridge splitting without creating a significant green stick fracture or taking a high risk. Obviously BMP2, titanium mesh, could be utilized. GBR, a classic GBR approach with PRGF or PRF and bone graft products. We have a lot of different options. So when we're dealing with these types of areas, obviously this is the area that we want to graft. We have to come up with the safest approach. And what we tended to do in this case is slightly expand the ridge utilizing BTI motorized ridge expanders. I was able to put in 5 implants, one where one of the implants failed, and I segregated the additional anterior implants. And I can see that most of the implants I was able to get in without a tremendous amount of implant exposure other than this implant in the maxillary right lateral position. Now, what we're going to do in combination here with implant placement is I will utilize PRGF and mix it with mineralized irradiated bone, in this case Mineros, and I will pack it around these defects as you see here on both sides. And I'm going to mix it so I have at least 2 millimeters of bone on the outside of the labial plate to give ourselves that buffer that we talked about to thicken the ridge. On top of the bone graft, we have for many years now have been utilizing the PRGF protocol from Dr. Nitwa. We're going to be here in this case utilizing fibrin. This is autologous material taken from the harvesting of the blood. We're going to use it as a barrier membrane, as a growth factor enriched autologous membrane to protect the underlying bone graft. And you can see all of the fibrin. One of the nice things about this material is that you can harvest a tremendous amount of fibrin, and we place the fibrin on the buccal, occlusal, and lingual aspects. At this time, because I wanted a longer-term barrier function, the fibrin membrane will only last about 3 to 4 weeks before resorbing. I then utilized with a tissue punch to go through these 3 millimeter high healing abutments. This is a Memlock, very large Memlock membrane that is utilized to cover over the fibrin and the protected bone graft with the PRGF material. We then utilized a releasing incision to be able to get primary closure over this very large grafted ridge, and always utilizing a horizontal mattress suture to first gain your tension-free closure. It's very important when closing in this area that the closure is done without tension. Once I get these horizontal mattress sutures, these are Vicryl, I'm going to leave them in for at least 2 to 3 weeks. I then use Gore-Tex suture over the top, and this is just a running mattress or baseball suture to close the remaining anterior defect and make sure that the bone graft is protected. Now we have the posterior implants supporting a fixed bridge, and there will be no loading of this anterior bone graft situation. On the left screen, you can see the temporary, making sure there's no pressure. One of the great things about having a fixed temporary is as we get the initial swelling, we're going to start seeing that this temporary is going to help shape the future soft tissue foundation. So what we ended up with in a case with very little bone is placing in about 11 implants to secure a fixed permanent restoration. So full maxillary fixed provisional is utilized during the healing phase. This is after a certain period of time in the temporary. The healing abutments have been exposed with extended healing caps for the restorative dentist. Now taken to the framework. This is a full upper framework for what was once a dental handicap patient with a full denture that was incapable of staying in the mouth with a very flat palate. And we really started with a patient, as you see here, with a completely deficient maxilla. We were able to place in substantial implants to support the final bridge work. Some people would ask, how many implants is necessary? If we look at the literature, you may say that for a fixed bridge in the maxilla, maybe 8 implants. But when you're dealing with all grafted bone, predominantly in this case, all the implants are placed in areas where there was no bone before. I think it's best to over-engineer the case and put in additional implants in case 1 or even 2 implants may fail. We certainly have enough implants to secure the fixed restoration that this patient wanted. So the treatment plan from fully dentulous to the full fixed implant case, done in stages, taking into effect treatment planning, different materials, and different bioactive modifiers, and making sure the sequence of therapy allows for minimal loading of the wound. Final bridge work in place. You can see the fixed bridge. We have adequate soft tissue fill in the anterior region, what was once extremely deficient, and the patient obviously ends up now with something that she can be quite pleased with. Just a few months ago, in the November issue of the International Journal of Peri and Restorative Dentistry, I was proud to be one of the lead authors of this article that was published with my colleagues, Dr. Ishikawa and Funado, as well as my team here, Henry and David, where we talked about 3-dimensional bones and soft tissue requirements for optimizing aesthetic results in compromised cases with multiple implants. And we highlighted this case in the presentation, a severe type 3 vertical deficiency. And what we talked about is how we can take deficient ridges and with a sequence of approach, we can rebuild these sites from type 2 and type 3 defects to type 1 situations. And let's look at another deficiency, maxillary anterior with a fractured bridge. You can see that this bridge had fractured 2 lateral sizes to support 4-unit bridge. Both laterals had fractured at the base of the posts, and we had to come up with a plan for this young patient. You can see on the CT scan where the teeth need to be, where the bone needs to be, severe thin ridge, incisor foramen, And as Mike mentioned before, not only for the lateral incisors, but in this case, the challenge of having adjacent teeth that need to be restored. We have 4 missing maxillary anterior teeth. We have a severe maxillary anterior deficiency, and obviously in this case, we're going to utilize autogenous block grafts and fixate it. We're going to mix it with autogenous cancellous bone, and we're going to screw it in with bilateral or bicortical fixation, might I add. Here we're utilizing 2 fixation screws on both sides. We have a split in the graft in the midline, and then cancellous bone is utilized around the outside. And really, today, what are our other current options? Some of us may not feel comfortable with such a graft style, or because of the morbidity of the patients, taking bone today from the ramus wouldn't have been sufficient, or maybe the chin, or in some cases, maybe the tibia or the hip. Or maybe today this is a case for BMP2 and for titanium mesh. How far can we stretch the envelope is the question that I think Synergy is supposed to be helping all of us answer. I have the questions just like any of the attendees, and I will press my dear friend Mike during the Synergy course about exactly how would you handle these cases today. This is one of my cases that I did with my oral surgeon in my office, Dr. Abtin Shariari, who will be at the Synergy course, where we talk about whether we should use BMP2, allografts, block grafts, autogenous bone, as we did here. What are the pros and cons? What procedure would work best? And what's the proper way to sequence the case? Can we mix and match some of these materials? Can we use BMP with some of the bone grafts? And would that help maybe our ability to use allograft instead of autogenous bone? These are all questions that I have as well. Regardless of what we use, I think this is very important. I think that Mike will solidify with me is that anything we do, whether it's bone or soft tissue, must be protected, stabilized, and must retain coverage throughout the healing phase. So tension-free closure, whether it's bone or soft tissue, is absolutely mandatory. We have to be able to release the flap, and you can see us releasing the flap way up in the vestibule to make sure that we can get closure of this very large augmentation. We then utilize the PRGF, the fibrin is then placed over the top to protect the particulate graft, and we placed fibrin in layers. So usually there's 3 or 4 layers of fibrin, and after about a minute or two, the fibrin turns from a yellow color to a pale color, signifying that it is set, and you will see that the graft material, because of the sticky nature of the fibrin, will stay in place and will not swim away. So we're going to use flap release. We're going to use PRGF and fibrin. And in addition to that, I always like to use a barrier membrane. As I showed earlier, I like a longer term for these types of grafts. I want something that's going to stick around a little longer. I know that Eduardo Anitwa, who is going to be present at the Synergy meeting, may tell you that he doesn't really feel he needs it, that fibrin membrane will last 3 or 4 weeks is adequate for most grafting procedures. But for these types of large grafts, I prefer to use a membrane. In the last case, I use a Memlock. In this case, I utilize a large piece of alloderm, which I impregnate the alloderm in the PRGF, so I always like to add a bioactive modifier, and I soak it for at least 10 minutes after a 10-minute saline bath. I take this material, it has 2 functions for me. It functions as a membrane, and it also functions to add thickness of soft tissue to maintain the closure, as well as to give me further thickness of the soft tissue for the final restoration and aesthetics. Suturing again, horizontal mattress, and then we then do interrupteds, and we go ahead and we close the verticals. I like to make sure the verticals are 1 tooth over. I know a lot of people place it next to the teeth. We'll talk about flap design and suturing and post-op instructions during the course, but one of the most important things in the hands-on session is that we will talk about suturing techniques, tension-free closure, and stability. At approximately 4 months, you can see that the tissue has retained complete closure in this area. I like to use a Essex-style tooth-borne removable appliance, so there's no loading, and you can see when the patient smiles, we've now brought the tissue complex down within the aesthetic zone, which really creates a much more ideal result for us down the road. Now at approximately 4 months, we're going to go ahead, take a CT scan. You can see the blocks. We've been able to build out the ridge. Mike's shown you that beautifully. We know that we want to have at least a minimum 2 millimeters of bone on the labial aspect of the implants, and you can see this from Dr. Grunder's work with Dr. Grassis, and that this very important area of bone is extremely important because as we get remodeling, we're going to end up losing soft tissue stability, and we're going to have color changes that may occur. So very important to overcorrect when looking at implants as opposed to natural teeth. And we're going to talk about the differences, obviously, throughout our course in Orlando. Again, we can see the incisor foramen. We can plan our implants. We're going to place 3 implants. We got our bone thickness in front of the implants, and we can do this in 3D and on the axial sections. 4 months, we're going to go ahead, place our implants. We're then going to come back 4 months later and expose the implants with the same incision. The incision is going to be made to the palate of the crest. We expose the implants. You can see that we got good bone on the front. This is where the bone graft was placed. You can even see here we had to remove some of the bone from the top of the cover screws because the bone had grown over the implants. Now the big question, and again, people think it's just about the bone, but it is not. The whole idea of synergy is the synergy between our ability as clinicians to manage both the bone, soft tissue, that then leads to the restorative framework. And here, if we take a look, we made our incision, which is typical, something that we all learned probably when we first started doing implants. We moved the attached gingiva to the buccal, but what we end up with now is problems with denuded areas that are left exposed. And there's a lot of different surgical techniques for soft tissue on how to manage these areas. So let's take a look at where the problem sites are. We now have areas, if left denuded, we're going to lose tissue height in these areas. We're going to get bone remodeling. We dare not leave these areas exposed. So how best to uncover implants as second stage surgery is extremely important in implant dentistry, not just for aesthetics, but also to make sure that we have thick keratinized tissue in the right locations and that we have these denuded areas in the interproximals covered with soft tissue. What we used here is pedicle flaps where we rotated pedicles from the palate, and when we released the palate, and we were able to get tissue interproximally to almost completely close in these areas. So really a way to manage these deficiencies with what Patrick Perlacci would call finger flap technique. We rotate these little flaps, as you see here, from the palate, and we do this with rotating pedicles. And these are really very, very straightforward, but you need to know exactly how to make these incisions, and sometimes you may have to add a release in the palate to gain further closure. At approximately 3 weeks, when the sutures are taken out, you can see that the tissue has swollen over the tops of the healing abutments. We have a little bit of a delayed healing here in this area, but very, very nice soft tissue healing over the healing abutments. As Mike mentioned earlier, we like to place healing abutments at stage 2 to support the soft tissue. And then at approximately 4 weeks after uncovering, we can start shaping the tissue with the restoration. Dr. Garber can start to work on this. Very important that we don't over contour these areas of the restoration. So if you see blanching, as you see here, we like to reduce that, and only at the time where the temporary has fixed the soft tissue framework do we go to the final lab phase, try into the framework. Ceramics can then be placed, and in this case we can end up with a very, very nice restoration in an otherwise very, very damaged site. Tooth, implant, pontic with substantial amount of dense keratinized tissue with stable soft tissue margins underneath good bone foundation. And the color of the soft tissue, whether it's alloderm or autogenous tissue, really you cannot detect a difference. The bone levels, very, very critical. Does it maintain itself in these grafted areas? That's a big question to ask, by the way, with some of these new materials. Not just when you place the implant or come back, but do they last after loading? And we're going to talk about that as well, and some of these new implant designs to help us facilitate that. The importance of soft tissue, which was just recently published about a year and a half ago, where they talked about the importance of soft tissue thickness on maintaining the crestal bone. And here you can see they didn't graft the tissue on this implant, they did in this implant. You can see how that soft tissue at 12 months receded, and also radiographically they lost as much as 1.45 millimeters of bone at the top of the implant. So soft tissue is critical, not only for aesthetics, but to preserve bone as well, which has now been shown in terms of research. So can we do all this? Well, we have the ability today to diagnose the deficiency, to then plan the case, depending upon some of the recent technology, and things have changed dramatically over the years. But we need to diagnose, obviously here, a very severe type 3 case. And how do we get from this defect to this type of final restoration? Well, only through the staging of the case, planning multiple surgeries. In this case, 2 bone grafts were utilized, and titanium mesh. And only through these types of procedures and understanding the requirements can we end up with more predictable reconstructive dentistry. If you look at the literature, really a study that was done, a Cochrane systematic review of all the pertinent literature ever published on horizontal and vertical bone augmentation procedures for dental implants. It was done by Marco Esposito in the European Journal of Oral Implantology in 2009, and he concluded that there were complications, and they were especially present for vertical augmentation, and that they are common. So what we're seeing is the literature tells us be careful how to treat these cases, understand the limitations, must be able to manage complications. We spend almost an entire half day at the Synergy meeting just talking about complications.
So I'd like to thank you again for your time this evening with both Michael and myself. Again, as a small preview, this webinar was intended to kind of give you an idea of where we're headed in terms of future directions and in terms of bioengineering and biotechnologies related specifically to bone and soft tissue augmentation. Again, we'd love to thank you and welcome you to our Partners in Synergy live event, June 27th through the 30th at the Ritz-Carlton, Orlando, Florida. Thank you very much for your attention.